Well, welcome and thank you for joining us, Dr. Wasay. It is my privilege to interview you. And Dr. Wasay, for those of you who don't know him, completed his training in neurology here in Texas, not in Houston though, and is currently a professor of neurology at the Aga Khan University, Karachi, which is also my alma mater. He does juggle many hats, and I know you've served as a president in the Pakistan Society of Neurology, the Pakistan Stroke Society, in as well, it sounds like the WSO director, the World Stroke Organization. So that's amazing. Can you summarize for us, Dr. Vase, your past and current, research interests and pursuits?
Well, it's a long story. So I started my research in residency, and my professor, Dr. Roger Rosenberg, who was the editor of the Archives of Neurology, when I was first year resident, he told me that if you want to do research, just pick one disease. I asked him which disease. He said, it doesn't matter. Just pick one disease and just stick to that disease like for the rest of your life. And then like about 25 years ago, I started collecting data on cerebral venous thrombosis. So now, like over 25 years, we have about 50, more than 50 publications related to cerebral venous thrombosis, probably one of the largest databases in the world. And our research, our CVT group is probably one of the very active research groups. So CVT is a major part of my research over a long period of time. Now, for the last 10, 15 years, working in Pakistan and working in like low, middle income countries, especially Asian countries, we have done a lot of research related to stroke care, and stroke treatment and stroke awareness. So a lot of research related to stroke in the low and middle income countries, especially South Asia and West Asian countries. So that has been most of my research story. But on top of that, we have done a lot of advocacy work related to stroke and neurological diseases. So I was awarded like Advocacy Leader of the Year award by American Academy of Neurology, and I have been part of a lot of advocacy activities. We have organized many advocacy workshops at World Federation of Neurology and World Stroke Organization, and regional meetings like Asian Oceanian Neurology Meeting and Asia Pacific Stroke Organization. So that is another dimension which I have been working for the last 15, 20 years. Advocacy largely related to stroke, but other neurological diseases. Now, in Pakistan, I have developed an interest in infections and stroke because there's a very close link between infection and stroke. So that's what we have been doing for the last 10, 15 years since I'm in Pakistan. So we have done a lot of work related to TB and stroke and meningitis and stroke and other viral and bacterial infections and stroke. So this is again partly related to stroke. And other major area which I am working is training. So in Pakistan, there are like about 240 neurologists. I have trained about 50 of them. So this is one area that we have been working for many years. We are training general practitioners, general physicians, neurologists, students, nurses, and everyone, largely in the area of stroke, but other neurological diseases like multiple sclerosis and other problems too. So this is kind of the work I have been doing for the last 15, 20 years. I'm still working with World Federation of Neurology, and I have been the chair of the World Federation of Neurology Advocacy Committee for 4 years. So we started World Brain Day at World Federation of Neurology. So that has been going on for the last 6, 7 years, and it has created a lot of awareness related to neurological diseases. I'm still working with the World Stroke Organization as a member of the Global Policy Committee. And I'm also a fellow of the Pakistan Academy of Sciences and Pakistan Academy of Medical Sciences and advisor for Pakistan Health and Research Council. And I'm also part of the Prime Minister's task force related to biology, health, and technology. So these are the areas which I am actively working right now.
That is amazing. How do you manage so much? Like I said,
Because
you're juggling so many.
no,
Do
because I don't
Russell.
do anything by myself. So I just work with a lot of people, and this is also part of my training program. So for every work we do, we have students, residents, young doctors, young researchers. So now we have a group of like 25, 30 people who are working with us, who are very motivated, passionate, and they are very caring for the country and for the people. So that's why it becomes easy for you. Then you don't have to do everything, right? It's a teamwork. So we have been able to build a huge team across globe, which are very active, efficient, and we work as a team. So that's why it's not very hard to do a lot of things if you are working as a team and you have 25, 30 people working with you all the time. So we kind of assign each other, we help each other out. So this is how we work. For the last 1 year, since we have COVID, we have done a lot of research related to COVID. Our group has published about 10 papers related to COVID, and some of which have been like cited 50, 100 times in the last 2 years. So this is a teamwork, and this is, I think, the lesson I learned, that if you just do everything by yourself, then you just cannot go too far. But if you have a very good team working with you, then you get a lot of energy from young students and residents and trainees and junior doctors and fellows and researchers. So that's what our strength is basically.
That's amazing. I think that's beautifully said. I think teamwork makes the dream works, and it sounds like you're living the dream. And I think, coming from Pakistan, I know that's what we need. A lot of research, especially because, like you also mentioned in your talk earlier in the Congress, was the stroke population in Pakistan is so very different than what we see in the West, in the U.S., in the U.K., and Europe, right? Now, what are some of those differences? And do you think that we need to tailor our stroke treatment and care models to optimize management for this,
The major
population?
major issue related to stroke management in Pakistan as compared to other countries is that there is almost no contribution from the governments. It's all out of pocket. So people are almost on their own for stroke prevention and for acute stroke care and long-term stroke care. So that's a major problem. So nothing almost exists in government hospitals. Whatever stroke care is available, everything is available in private hospitals, but it's very costly and not accessible to most of the people. I think in Pakistan, the most effective strategy would be to work on stroke prevention, because you still have a lot of people who could be prevented from stroke. We have a huge burden of hypertension, and a lot of people don't even know that they have high blood pressure. So this is one area where we can work. Number two, we have a huge burden of tobacco abuse. Smoking has gone down, but chewing tobacco is very, very high. About 23% population in Pakistan, adult population, is using tobacco. So this is another important area of for primary prevention. And the third, I think, most important area which we have recently discovered, and we are facing a lot of challenges, is air pollution. Now, air quality index in Pakistan is extremely poor, especially Karachi, Lahore, which are the big cities. The average air quality index lies between 150 to like 200, 230, which is pretty much very polluted air, and that is causing probably a very high burden of stroke and other non-communicable diseases. So this is another area which we have started recently working in the last 4 or 5 years, and I am currently secretary of the environmental neurology group of World Federation of Neurology, because we have learned that if you want to address a lot of neurological problems, you have to fix the environment. That's a major primary prevention step, though there's very little awareness related to that. But I think in Pakistan, it's going to be very important. If we are able to fix, I think we will be able to decrease the burden of stroke. So these are three key steps, I think, as far as public awareness is concerned, is to reduce control blood pressure, to reduce tobacco, and control air pollution. I think these are very important steps for primary prevention. Another issue related to stroke in Pakistan is that a lot of people, they go to hospital, they get acute care, they get discharged, and we have a very high mortality after discharge. Like our 30-day mortality is 60%, but if you look at like the 6 months or 12 months mortality is 40%, which is like I never heard of this kind of figure in the Western population. Most of the people who get better, they continue to get better in stroke with a stroke over a period of time, and they are able to work even after 6 months or after a year. But here, most of the people they die when they go home, and probably they quit taking medications. They don't get the care. They are kind of very demotivated. They get depressed. They don't have any will to live. Probably this is one reason that they kind of lose interest in their life, and that's probably why they lose their life, because I think they don't have anything to do in future. So this is so disabling, and this is another important area for us to work, is to improve the post discharge care, so we could help people to get reintegrated in the community, which is almost non-existing. Though we think that most of stroke patients, if they are treated well, they can go back to work and they can be very functional. So this is, I think, a very important area for working for us in the coming years.
I think you have absolutely addressed one of the questions that I had. I think the numbers when you presented in your talk were very shocking, even to me. Why such a high mortality? So are you saying that, suicide is probably underreported in Pakistan as a result of depression? Do you think it's more complications from stroke, or do these patients have another stroke, or what is the reason?
What we have searched for, like once we talk the families that what happened to the person, a lot of time they quit taking medications. Number one, number two, they develop infections, especially upper respiratory tract infections. So that's another major problem. And sometimes they have recurrent strokes and lack of rehabilitation. I think depression is an important factor, because for stroke rehabilitation and recovery, you need a very strong will. And if you have a patient who is not even willing to live longer with the kind of disability they have, then it's very hard to motivate and rehabilitate those patients. So probably depression is also part of the problem, but it's probably all of the above. And the family support, financial burden the patient faces and the family faces. So these are the things which makes the patient don't want to live longer, and that's one of the reasons.
You're absolutely right. I think so. We've identified at every stage, right? Prevention, primary prevention, addressing the three key things that you talked about, treatment, lack of access, and, like you said, government hospitals, most people can't afford private hospitals, which can still give you. Even despite that, a lot of people, just because of low awareness, do not come early enough within the window for thrombolysis to the hospital, and then problems after discharge with rehabilitation. So it sounds like every step we're facing challenges. What are some of the practical solutions in our society in Pakistan that you think can help,
Well,
address prevention?
there are major areas. I think we are also working with the government to improve the situation in the government hospitals. We are training doctors, I think, which is a very important area. Most of the doctors, uh, they did not get good training at the medical schools related to stroke care, and stroke care has changed so much in the last 10-15 years. So we are training doctors and nurses. We are also training family members and attendants on how to take care of patients. But there's a lot of training which is required. The critical neurology mass is still very low in Pakistan. So they are like the main persons who are going to treat stroke. And there are only about 240 in the country. So it's about like 1 per million. It should be like 1 per 10,000. But so we have a very low critical mass of neurologists in country, and they are the one who are basically trained to provide stroke care. Most of the general practitioners and general physicians and family physicians, they are not good at treating stroke patients. So we are training doctors and GPs and family physicians, internist. But I think one important area for us would be to have more neurologists in the country. You know that in US there are about 500 Pakistani neurologists, but in Pakistan there are only 240. So which is half of the Pakistani neurology population in country. So that's one area that we want to improve, is to have more neurologists in the country, more people trained related to stroke. And our target is to train a lot of general physicians and doctors. And at the same time, we are working with the government and we are doing public awareness. We are generating data related to stroke because that's probably what is going to convince the medical community and health community and the government to invest in stroke treatment. So this is all the things which we are doing. We have a very active stroke society. Now Dr. Anjum is the president. She is a very active fellow. She was trained at AKU and she is based in Balochistan, Quetta. And she has done a tremendous job in running the society, and she has created a lot of networking with the thrombectomy group, MT 2020. We have started thrombectomy in many places in the country. And we are still struggling to get TPA in the country. TPA is not available in Pakistan yet. So we are working with Beringer for many years to get TPA. And hopefully, once the TPA is available, we may see a lot of improvement in stroke care because that kind of gives hope to a lot of patients and the doctors.
Excellent. And that brings me to 2 points that I wanted to raise, with you was, TPI I know is hard and it's expensive, right? And since, a lot of people are paying out of pocket, what do you think? Do you think there's any role of TNK or Tenecteplase in Pakistan? It's
Well,
cheaper,
the
possibly works
Tenecteplase is
better.
not cheaper in Pakistan. It's the same cost as TPA.
I see.
So Tenecteplase is available in Pakistan, but it costs the same as TPA. So it's not any cheaper. So sometimes even it's more expensive in some cases. So it's probably a Boehringer product. So it's not cheaper, and availability is also an issue. TPA, it was approved by the Drug Regulatory Authority of Pakistan this year, and we made a lot of effort. The Pakistani Stroke Society did a lot of lobbying for that. But even after approval, Boehringer has not been able to bring like a TPA in Pakistan. So hopefully they will be able to bring TPA. Now we have commitment from the government that government will make TPA available in large centers at the city, several hospitals. So we hope that if the TPA is available and it's available at the government hospital, then a lot more people will be coming to the government hospitals for acute stroke care once they know that something is going to be available and something is going to happen at those hospitals. So it may change the way people think about a stroke.
Excellent, excellent. You're absolutely right. And can you also talk about what is our current progress and update with thrombectomy? And you briefly mentioned that we are involved with MT.
Now, at this, we have three centers who are doing thrombectomy in Pakistan. One is a public hospital, which is in Lahore. There's another hospital, services hospital, is going to start soon. There will be two public hospitals in Lahore, which is Shifa, and one private hospital in Karachi, which is Aga Khan. So these, there are 3 or 4 centers who are doing thrombectomy. But we have recently trained doctors in Peshawar and Quetta, and hopefully we'll be training doctors in Multan. So these centers will also be starting thrombectomy in 2022. So we have a plan to start altogether 6 or 8 centers who have thrombectomy facilities in the large cities by 2022.
Excellent, excellent. Well, that is fantastic. And then just briefly touching upon, and we may have briefly talked about it already, but rehabilitation, right? I know we don't have any inpatient rehabilitation centers, and that is, something that we can use. How do you think, and how do you think we can improve current rehabilitation after stroke in Pakistan?
Yeah, most of the rehabilitation is outpatient in Pakistan. So patients do not go from hospital to a rehabilitation center because we don't have any inpatient rehabilitation center for stroke patients anyway. So they go home from the hospital. Most of the rehabilitation services are provided at home. So at this point, there are like 2 ways. There are about 3,000 physiotherapy doctors in Pakistan who have got a degree of DPT. So that's a good number. And they go home and they provide home physiotherapy. And another area is family. So a lot of time, because now everyone patient lives with family, so we train family members, their daughters, their sons, the patients family members, we train them how to do physiotherapy. So they kind of do a lot of physiotherapy work. So most of our patients They initially have physiotherapy for like a few weeks by the physiotherapist because it's still very expensive. Home physiotherapy cost about in Pakistan is about 700 to 800 rupees per day. That's a lot of money for a lot of people. So most people cannot afford months of physiotherapy at home, but they do get physio at home for a few weeks. Then in the meantime, the family members to learn how to do physiotherapy and start doing it by yourself. So a lot of time they do a good job.
Excellent. Well, that was really interesting. I think really learning your insight into prevention, treatment, and rehabilitation. One last thing that I wanted to ask you was secondary prevention of stroke. I know it's, a lot of our folks unfortunately, pass away pretty soon after the mortality is so high. But for those who do not, what are some of the things or investigations that we do, to address that?
Well, most patients, like if they go to a private hospital, they get the whole stroke workup, like they get echocardiogram, they get lipid profiles, and they get Holter monitor. A lot of patients, they don't get that kind of care. So most important, like for us, is the immediate care because they should get a swallowing assessment. They should get like a NG tube because aspiration pneumonia is very very common. So that's one issue which I think we have to address. They don't get a full secondary prevention stroke workup, but they do get part of the workup. So most of the time they are discharged on a statin, they are discharged on antiplatelet medication, a blood pressure medication. If they have diabetes, then they are discharged on a diabetic medications. The problem is that they don't continue it for very long period of time. Probably part of that is affordability because medications are expensive and a lot of people cannot afford these medications for very long period of time. So in acute stages, they are able to afford, but for long period of time, sometimes they cannot afford. So that one issue which translates into more strokes and recurrent strokes. And sometimes they don't get a very good discharge counseling, so they don't know well that how they have to take these medications. Sometimes they if they run out of medication or they run out of money for some period of time, then they quit taking medications. That's probably why we have a very high post discharge mortality,
Mhm.
or 6 months or 9 months mortality is pretty high. I think it's probably they have recurrent strokes or they get infections or they have complications of their primary problem because a lot of them, they are diabetic, hypertensive, dyslipidemic, and largely they don't die of stroke. Like they die of heart attack, they die of other problems because if they don't continue to take medication. So that's probably one major issue. That for secondary stroke prevention, I think we have to make the care for secondary stroke prevention affordable, and so people can take it for longer period of time, which is, I think, a problem.
So just a clarification, you mentioned that you were training internists and general doctors. Is that for the acute treatment of stroke or more for identification or post-stroke
All,
management?
all, all three. Our module has all three. Number one is acute identification of stroke. So we are training fast symptoms and then acute management of stroke, especially blood pressure control, nursing care, stroke unit care kind of thing. And then we are also training about secondary prevention and some part about rehabilitation and primary prevention too. So kind of we are trying to train everything because a lot of people, because these GPs, they do see a lot of healthy people, and they do have high blood pressure, diabetes, dyslipidemia. So if they can identify them early and they can treat them early, I think we could prevent a large number of them from developing stroke. So we train them about primary prevention too.
That's great. And I realize it's past midnight in Pakistan. So, there's so much more that I have to ask you, but, I obviously want you to get some sleep. One last question that I was hoping to ask you, Dr. Vassi, was you mentioned something about the mobile stroke registry. Can you just tell us
Yeah,
what
we
that is?
just starting, and this is very unique because once we started this registry, we got a phone call from Apple iPhone. They said that this is the first time we have seen a research registry in in the Apple system. So what is this? And they asked for a lot of paperwork from Bioethics Commission approval and everything. But at the end, they allowed us to do a mobile app based registry. So we have started this registry last year, and we have enrolled more than 1,000 patients. So about 40 neurologists across the country. It's an iPhone and Android app which you can install in your phone, and you can register as a participant, and then you can start collecting data on those patients. It's pretty easy. It takes about 3 minutes to submit a patient's data if you have the data. So we are collecting about 100 patients a month from 30, 40 centers across the country, and hopefully that will give us a lot of, because this is the first national registry. So hopefully we will have a lot of information related to stroke risk factors and outcomes, uh, and what are kind of workup they are getting. So hopefully this will translate into a lot of practice and policy change in future.
I love it. I think that is absolutely brilliant. I mean, I know that in Pakistan, we may not have good internet connectivity in some places, but every other person has a cell phone, and getting patients enrolled through this way, I think that's a stroke of genius. So excellent idea, and
We
I
have
think you get some good information out of it.
Dr. Aisha Kamal is our professor of stroke neurology, and she has started a lot of studies related to mobile health. So she has used mobile phones for reminders and teaching the patients related to stroke, and she has done very good randomized controlled trials with very good results. So that's also a very strong contribution, that we can use this mobile apps and mobile technology in promoting care. We are also working with the World Federation of Neurology. We have suggested that all the mobile phones, they should have sensors for air pollution. So we should be able to calculate from iPhones and Apple watches and smart watches the level of air pollution around you, and then you can calculate the air pollution around you, and you can identify that, how you have to stay away from the air pollution. So this is something which is going to happen maybe next 4, 5, or 10 years. But there's going to be a very strong contribution from the mobile application, that you should be able to sense your environment, and then you can modify or adapt yourself according to the environment.
That's interesting. I think at least in my iPhone, in the weather app, it does show like the quality of air. I wonder, but I don't know how they sense it or measure it. So I think it's just like a general Houston has
No,
this.
they don't have they don't have a sensor, but they get this data from the local centers. So each city has some centers where they collect data related to air quality index. For example, there are like, for example, if you are in Houston, there may be 10 centers who are looking at the air quality data. So your mobile phone gets the data from those centers, and then just transmits you that information. It doesn't sense by itself. But maybe in future, because if you can have micro sensor, then at least you could detect particulate matter 2.5 or 10 or ozone. So these are the things you can detect from these microprocessors or sensors. So then you should be able to calculate your own environment, like the environment around you.
Well, that's super fascinating. And you brought up Dr. Kamal. Dr. Aisha Kamal is the reason I went into stroke. She's been my mentor. She is the lady, who I wanted to emulate and
She
be
has
like, I've
trained,
got to fix the cobras.
probably she has trained about like 20 stroke doctors in country. The most you could see a lot of them, they are outside country though, but she has trained she has trained the best stroke doctors in the country.
That's amazing. And she is phenomenal. So I think you guys have a good group over there and you're working on so many things. It would be a privilege for me also to come and contribute to that research and also some of the practical
Also,
implications.
stroke here in Pakistan sometime. Maybe you should give lectures and teach students and residents. We are working with a lot of Pakistani neurology and stroke doctors based in US and Middle East and in UK and other parts of the world. So maybe you should also work with us.
Absolutely. I'm happy to sign me up for any opportunity, Dr. Vase. I will be
Okay.
in touch with you. Thank you so much for your time, especially that late at night. I appreciate it. And I think this was a very, very helpful conversation I learned a lot, and I'm sure people who have access to this recording will also learn a lot. Thank you so much.
Thank you very much.
Assalamu alaikum.